Hello, everyone, and welcome to the IMA Weekly Show. I'm Dr. JP Saleeby, and IMA Senior Fellow specializing in Functional and Integrative Medicine. Inflammatory bowel disease, or IBD, affects more than 7 million people worldwide and includes conditions such as Crohn's disease, CD, or ulcerative colitis, UC. Patients are often told that these diseases are genetic, autoimmune, or in many cases, idiopathic, meaning that the underlying cause is unknown. But do these descriptions still fit the available evidence? A new paper published in the latest edition of the Journal of Independent Medicine, when you can see the entire article on journalofindependentmedicine.org. That and I co-authored, and my guest today is actually my co-author and lead author of this, and we're here to challenge all three of those assumptions. Rather than viewing IBD as a genetically predetermined or immune system simply attacking itself, the paper proposes that there are many more accurately understood as partially hereditary, environmentally activated, and immune-mediated inflammatory disease. That distinction could change how we think in medicine about prevention, treatment, patient communications, and future research. So help me join today our guest and my co-author, Mr. Josh Dech. Josh is a gut specialist who works with people affected with Crohn's disease and ulcerative colitis and other gut issues. He is also a podcast host and a common sense critical thinker committed to helping people better understand factors of many that may contribute to these chronic digestive illnesses. Josh, welcome to the program.
Oh, it's an honor to be here, JP. And thank you for the compliment. Being a critical thinker in 2026 feels like a superpower, but it's an honor to wear that crown.
Right. For many of us that tune in, we all are critical thinkers on this program. Josh, let's begin with the central argument of the paper and why we felt that this discussion was necessary. So most people with chronic Crohn's disease and ulcerative colitis are told that they have a genetic autoimmune condition that has not been clearly identified, that it's incomplete and potentially misleading about this explanation. Can you touch on that a little bit?
Yeah, I'd love to. Western medicine has this very reductionist point of view, right? And I know everybody listening, I'm sure I'm preaching to the choir. It is one organ, one system, separate from the rest. Nothing's working as a whole. And the issue that we run into with this, even on like the broader scale of where we see medicine going, separating these organs and these systems, these individual little parts, ends up leading us to really silly solutions. For example, right now, one of the things they're looking at in bowel disease is actually CRISPR. So they're doing gene editing to modify the genes of children and adults and not even developing fetuses, but full adults. They're trying to change their genes to try to correct and reverse the disease, which in one end we go, well, yeah, okay, your genes are overreactive, which I'm sure we'll get to. But on the other hand, your genes aren't the problem. They're simply a weak link. And this entire framing that we have really leaves us with two ultimate solutions. All right, we go to your doctor and they say, yes, it's genetic, autoimmune, idiopathic. We don't know what's causing it. Therefore, solutions are surgery and medications. If that's the only solutions we have, it makes sense because the framing is so wrong. what we're going to be able to or have a chance to do today on this call was really flip this on its head to understand it from a completely different lens. And by the time we're done, there are doors flying wide open onto what's possible for this disease in the future. And that's why it's so important and why, it's kind of a misleading explanation why that's a problem.
Right. And like you mentioned, the language needs to change. And to describe this disease, it does matter what we call it and how we think about it,
Mhm.
especially when we label IBD as unavoidable or idiopathic. And I have my own definition of idiopathic: idiot doctor and pathetic patient. I'm stealing that from an oncologist who used to use that to identify idiopathic. But that means we just don't understand it too well. We
Mhm.
don't understand what causes it. But we're here tonight to offer some different options for patients and clinicians to think about things. Um, let's talk a little bit about one of the best known Crohn's disease risk genes is something called NOD2. Yet only about 20 to 40% of people have this homozygous um, condition or in genetic makeup. The NOD2 risk variants develop Crohn's disease. What can you tell us about that and its penetrance?
Yeah, let's define penetrance. In these cases, we're talking about the percentage of people with this disease or with this gene and these particular markers who actually develop this disease. So we look at NOD2, it is the single strongest genetic association we have for Crohn's. 20 to 40% penetrance, the rest are maybe up to 5%, give or take. So understanding what it does, that NOD protein, NOD2 protein, acts as this intracellular immune sensor, and it recognizes these bacterial molecules and it triggers immune responses. And its job is to defend against infections. We want that. Like, that's a good thing. The problem is it also triggers things like autophagy, and that's a bacterial cleanup crew. When these things get out of whack or out of balance, we have these altered genetic responses, things become a problem. And so over the last 20 years, they actually identified a couple different variants of this gene, the R702W, the gene 908R. There's a couple of them like that. And that was 20 years ago. Now, if you carry two copies of any risk variant, you're the highest Crohn's risk profile known to science today. Your odds ratio is actually 17 to 40 times higher for getting Crohn's disease than anybody who doesn't have it. So it's enormous from any epidemiological standard. And so what we see though is that again, only 20 to 40% of these people who carry these genes actually develop Crohn's. The 60 to 80% left over never get it, despite carrying the worst markers you can have. And so what this tells us is that genes, they create susceptibility. They don't create disease. That's the whole narrative being flipped. So if Crohn's were genetically determined, like we're often told it is, then these highest risk genotypes would produce Crohn's in almost 100% of carriers. Right? That's genetically determined by definition. But NOD2 doesn't even come close to that. And if we compare it to actually genetically caused diseases like Huntington's, cystic fibrosis, sickle cell, they're 100% or nearly 100%, whereas these NOD2s are 20 to 40. We know Crohn's, for example, is roughly 3 to 5 times less penetrant than diseases we call genuinely genetic. Again, Huntington's, cystic fibrosis. And then the twin studies, we look at these. There's twin studies back from 1988, and they were redone again and carried further through 2007. But they actually show us that identical twin concordance, so identical twins both getting the same disease, is just 30 to 50%, though they carry the same DNA. In ulcerative colitis, it's like 15 to 19%. And so if one identical twin has Crohn's, then the other twin who shares nearly identical DNA only has a 30 to 50% chance of getting the disease. Again, for colitis, it's like 15 to 19. And so it doesn't make any sense. This is where we have to reframe our language to go, well, the problems we're seeing is that the language doesn't make sense. So what does? If one develops disease and the other one doesn't, the difference between them is by definition, it's not genetic. It's got to be your diet, antibiotics, smoking status, appendectomies, infections, stress, life events, all these other things that actually make the difference. So, I mean,
Right.
that's my humble opinion.
Yeah. So that NOD2 is one of possibly 240 different genetic risk loci. Loci are on your DNA or on your chromosomes
Mhm.
that are associated with inflammatory bowel disease. But you're right. If genetics was it, anyone with those mutations or those genes would be at increased risk, and we'd see way more cases. What can you tell us about children immigrants from countries where the relative low IBD incidence can develop the disease at rates that approach those of their new host population? In other words, when people immigrant, little kids, for instance, immigrant from a
Sure.
country that was having low incidence of IBD. All of a sudden, they're here for a few years and it's expressed. How does that fit into this new theory?
It's really interesting. Those, just like you said, those immigrant studies, within one generation, they're already getting IBD at the same rate as the host country, coming from a low risk incidence country. For example, if you took somebody out of rural India and moved them to Canada, their risk is as much as 100,000% increase of getting bowel disease, which is, it's unheard of. And that's the data. I'm not making this stuff up. You can pull this data apart because they still eat real food. They still breathe real air. I mean, again, the urban or the more rural, not super hyper industrialized parts of the drinking out of the Ganges River. But that's the idea, is our countries and everything we're doing to ourselves are the drivers of these diseases. These genes that we say, well, they cause disease, they don't. It is the weak link. Our environments, external and internal microbiomes, toxic load, etc., are what pull on that weak link to make it break, which ends up developing these diseases. Has nothing to do with the genes themselves. I won't say nothing, but so
Right.
little to do with the genes themselves.
Right. You're talking gene expression, epigenetics. So there's other factors
Yes.
outside of the genes that will cause expression of this disease. One thing we should, Josh, talk about is the terminology autoimmune versus immune
Mm.
mediated. Can you touch a little bit on that and the differences between the two?
Yeah, I'd love to. So, immune mediated just means that the damage comes from an overactive immune response, right? If you have an overactive stress response, start punching the wall, your hand's going to get damaged as a byproduct of that stress response, kind of just by proximity of being near the stressor, right? It's not from the immune system deliberately attacking the tissue. Your immune system, it's responding to something that's really legitimate. It's there, usually, again, a microbial or environmental trigger, but the response is too big and it doesn't shut off. And then that surrounding tissue gets caught in the crossfire. It's kind of like, again, it's like the bystander effect. Sometimes, yes, it's going to be specific cell populations running a bit heavy. There's cytotoxic like NK cells. They can become overreactive and kill cells that they should have left alone. But sometimes it's like cytokine production, right? It's appropriate to scale for a short exposure, but if it never turns off because that exposure never leaves or that imbalance doesn't get rebalanced, of course it's going to keep going. And so the difference there is an overreactive immune system that's called immune mediated. When we talk about autoimmunity, it's very simple. Autoimmunity, the immune system is aiming at your tissue, right? Like a sniper rifle locked onto a target. In immune mediated diseases, it's aiming around the tissue, right? And the tissue takes damage from being too close. It's really all it is. IBD, we know, is to be the second. And something that's really interesting is that when we look at classical autoimmunity, there is criteria it needs to be met, and that's called the Witebsky-Rose criteria. There's three things you need to be classically autoimmune. The first is transferring the antibodies or the autoreactive T cells from a patient who has the disease to one who doesn't, to reproduce the disease in that body. It's been shown for real autoimmune conditions, right? Graves' disease, if like a pregnant mother, right, has thyroid antibodies, they can cross the placenta. The baby is born with hyperthyroid. It's the same disease, and it's transferred by the antibody by itself. The second thing that we need is immunizing an animal or the target with tissue that has to reproduce the disease. So it's like you're taking this diseased or tissue that's being attacked in the sick host and you move it to the healthy host, and their immune system will learn to attack that tissue. The third thing you need are these clinical markers of autoimmunity. So any autoantibodies against specific self tissues or self antigens, lymphatic infiltration, HLA associations, any responses to like immune suppression drugs that they respond. It's just more of a parallel. IBD, it doesn't meet the first two. It only meets the third. There are some auto antibodies, HLA links, etc., that may have been seen, but there's no actual production or self attack. So they've been classed under the same umbrella, but it's not the same thing. They've never been reproduced. They've tried and it's failed every time. Every animal model has actually failed this transferability until you introduce environmental triggers like chemical irritants and things like that. So this language of autoimmunity self-attacking, just like before, it goes, well, there's nothing I can do. I'll take the drugs. But if you go, wait a
Mhm.
minute, it's simply an immune overreaction to something stuck in my body, like a nail stuck in my foot. I can put numbing cream on it the rest of my life. It's not going to fix the problem, right? It is
Great.
something your body's reacting to that was never removed. And so the reaction gets greater and greater and greater until tissue becomes damaged. That's all it is.
Right. Right. Some of the viewers might understand this or might hear immune suppression medications and how they can reduce inflammation. And they might ask, well, doesn't that prove the disease is autoimmune? If you take, let's say, prednisone or a monoclonal antibody or something, can you explain why responding to immune suppression shows that the immune system is involved, but not necessarily identifies it as an autoimmune condition?
Yeah. Let's talk about that third criteria of Witebsky Rose. We talked about the first two, which is transferability of disease. The second is just long immune reactivity. You know what else shares category three along with IBD? A bee sting, a chronic inflammatory injury like a recurring sports injury like tennis elbow. Those share the exact same types of responses. So if I have a shoulder injury and it hurts, it's inflamed, and I take ibuprofen and it responds, does that tell me it's autoimmune? Of course not, right? It is an immune response of inflammation, which is there to heal you. Its job is to heal you, to increase blood flow, to bring in healing cells. All these things create pain and inflammation. If it goes on long enough, the tissue breaks down. By suppressing that inflammation, you manage the symptoms and you can stop or halt the breakdown, giving your body a chance to catch up, but it doesn't fix the problem. And that's exactly what we're seeing in IBD.
Right. Another example would be sunburn. So you go out to the
Mm,
beach and you get a really bad sunburn, and you can cool it down with topical cortisone cream. But sunburn is not an autoimmune disease.
of
So
course.
sometimes the same therapy can be used for both autoimmune and inflammatory conditions, but you can't prove it to be autoimmune by just using a drug. So
Yeah.
our paper actually identifies several environmental uh, contrib- contributors associated with IBD, including smoking, antibiotic exposure, urbanization, oral contraceptives, air pollution, even psychological stress, and we'll get to ultra processed foods as well. Now, our research actually did a dive into available research, and it's listed in our references. But that concluded in January of 2026. I don't think we included any studies after that period. And there were two additional studies that were published in open source. The papers were published in real time since January, and of course, different institutions and different authors contribute ongoing. There's hundreds of papers that are being peer reviewed probably every week. So there was one study that we did not include in our paper that had to do with the relationship between IBD and ultra processed foods and the microbiome and
Mm.
intestinal inflammation. Do you want to tackle that topic?
I'd love to. We were just talking off air, and I'm going to talk about this as hypothetical because the paper's not finished or published. But we look at ultra processed food. I kind of look at us and I'm like, are we idiots? If I put urine or sugar in a gas tank, the car is not going to run. If you put food that's not food into a gut, not meant to handle that food as fuel, it's not going to run. And this paper I'm looking at is actually comparing industrialized versus industrialized nations, which to my knowledge is the first of its kind. If we look at the Southeast Asian populations, South Korea, Taiwan, Japan, etc., they're roughly, even rural China, parts of rural China, they're about 35% of the global population. They have about 6% of the bowel disease. In the Western world, We are, again, Canada, US, UK, Australia, New Zealand, like the Anglosphere. We are about 6% of the global population. We make up to 60% of the global documented cases of bowel disease. Well, coincidentally, the reason we have 5 to 25 times more bowel disease than they do, we compare the habits and lifestyles and environments of industrialized to industrialized Asian versus Western countries. The biggest differences we see, big one is, of course, yes, antibiotic exposure, but ultra processed food. Ultra processed foods make up to, on average, depending on the study, about 67% of the average American or Westernized diet. Whereas that rural China, Taiwan, Japan, South Korea, Vietnam, they're 5 to 25% of their diet, more so in, again, like Japan and upscale countries. So we use more antibiotics, more agrochemicals, more glyphosate, more birth control, more every risk factor. But the ultra processed food, from industrial to industrial, is bar none one of the, I'd say, top three of the 100+ risk factors that I've looked at in this paper. So it absolutely is devastating on our gut microbiomes.
Yeah. And I think if we look at treatment, we look at the current biological therapies that target certain pathways like TNF alpha, tumor necrosis factor alpha, interleukin 12, and IL-23, integrins, JAK signaling, and Th17 activity. They're very popular, they're fairly expensive. You see advertisements for them on television all the time. How does the environmental model complement the use of these medications rather than simply rejecting them?
I could see how that might almost sound like a trick question or like a sneaky one. It's not though. And the environmental model, it doesn't reject medication. In fact, you could argue it actually supports their use. Right? Environmental factors, they're part of what drives these inflammatory immune pathways that the medication can suppress. Right? You can suppress inflammation, you can get back to your quality of life without ignoring environmental drivers. I've seen clients in my practice with 50 bowel movements a day. They wear diapers, they've got buckets in their car, agonizing pain. Gentleman I just started recently here in my practice, he's 5'9" and 99 pounds, right? At that stage, there's very little we can do immediately because your body's so frail and reactive. So we got him on Rinvoq. It's a great drug for what it does. My issue I take with these drugs, we have these chronic inflammatory conditions. We take acute treatments and then apply them chronically. And that's no way to get better. It's like numbing cream on the nail. Every time it wears off, you put a new dose. So suppress inflammation, manage that, get your quality of life back. But don't exclude the, like, one, they're not exclusive of each other, right? It happens if we're willfully ignorant. And so there's a lot to look at, you know, in this whole conversation about does the environmental model ignore drugs? That's kind of the simplest answer I think I can give you, is that no, it doesn't. They complement, but the drug model ignores the environmental model. Does that make sense?
Yeah, absolutely. And I think the thinking with mainstream medicine is that once they start folks on medications or a biologic, it's for life. And it doesn't necessarily address the underlying reason for why this is happening to a person. I mean, that's kind of ignored. It's like, oh, well, we've reached the diagnosis with whether via like colonoscopy or some lab work or just how they present. And the drugs seem to work. And they're sort of I've heard clinicians warn patients, oh, never stop this because you might not be able to get back on it again, or you might be resistant. You might be resistant to this agent if you ever stop it. So it's kind of this propagation of, continual use of pharmaceuticals and biologics, and that's really a shame. I mean, I could see using it temporarily to suppress it. It's like you take an ibuprofen for a headache, but then you need to work up that headache to find out what the root cause of is. It's not
Yes.
appropriate to take ibuprofen forever, you know.
No. And
Um,
between the top 10 medications, JP, you can take for IBD, like these, any broad immunosuppressants, biologics, there's over 200, something like 202 or three different side effects. And that's including everything from infection at the injection site, et cetera. But cancer, heart attacks, strokes, Steven Johnson syndrome, where your skin just falls off your body. I would like to avoid that if I could. And
right.
this data sounds scary. Stop the drug, you get antibodies. But the reality is, 1 in 3 patients have no response to their first drug anyways, which can take sometimes months to get into. If they do get benefits, 1 in 6, 1 in 8 will lose those benefits in a year. Up to 75% end up changing drugs anyway at some point in the first couple of years. 50% of Crohn's and about 15 to 18% of ulcerative colitis need surgery in their lifetime. So this whole thing, the whole drug model is kind of crazy. And since 1955, when they first started using prednisone, we were asking the question, what does this drug do to IBD? Like, we spent enough time asking, or we haven't spent enough time asking what actually causes this disease. What are the specific root causes? Instead, we're just saying, what does this drug do? Which is insane. We should investigate histories, pool the data,
Mhm.
do better jobs of determining root cause drivers and factors. And like that paper I'm working on now is a great example of that. But medicine and literature waits until you have the proof and the replicatable studies, which frankly we never get because journals don't want articles that are not novel. So we only get one.
Right. Right. So, with some of your patients that you see for uh, Crohn's and ulcerative colitis, because we have a lot of clinicians that tune into this weekly webinar, what upstream areas might clinicians reasonably evaluate along standard gastroenterology care? So a GI doc will do his workup and do some things. But what are there things like thinking outside the box should they be doing to address folks with these chronic problems?
Mm. I mean, antibiotic history is huge. I don't have the numbers off the top of my head, but it's something like a 67% increase after one round of antibiotics of a risk factor. It's 147% or something like that for early on, like before 5 years old, as that microbiome is developing. So they're huge drivers. But when I assess a client, I'm looking at everything as far back as I need to, and oftentimes as far back as I can. I will literally ask a 50, 60-year-old man or woman, were you C-section birth or bottle fed or breastfed? What kind of early infections did you have? Was there tonsillitis, ear infections, asthma, allergies, skin issues? Because kids don't get sick unless there's A, an environmental driver, B, garbage food, or C, they weren't breastfed properly and the environments around them are causing problems. It really falls under the three things of toxins, microbes, deficiencies. It's the only reason we get sick. Everything can, I mean, getting hit by a bus doesn't count, but everything else falls under those things. So what was happening in your teen years? Was there bad diet, going out to McDonald's with all your friends, drinking in college? Did you live at home? Was there stressors? Was there traumas? College dorms are notoriously moldy, right? All these things matter. And what we do, we can't prove any of this stuff. This is the difficulty. This is where our critical thinking clinician cap comes in. We have to look at the body like a cup of water over
Mhm.
all the years. What are the things that filled your cup until it finally was ready to overflow? Once we have that information, then we can start working back and saying, what's the biggest issue now? I can look back and go, 10 years ago, you were exposed to mold. Huge driver, hard to prove, but the mechanisms are there. I can look at that and go, yes, there was mold. Is there mold now? No. Am I worried about mold then? No. I'm worried about the residual damage that the mold created, right? Dysbiosis, fungal infections, immune hyperreactivity, Th1, 2, and 17 dominance, mitochondrial damage, on and on the list goes. Then we know what to investigate top of funnel. Otherwise, we're guessing.
Right. Right. I get the whole, diet quality thing for sure, and stress and smoking and alcohol overuse
Yeah.
and environmental pollutants. But now you said you asked your questions about whether they were C-section or vaginal delivery and if they've been breastfed. Now, for those in the audience that may not understand the relevance of those questions, would you, talk a little bit about that?
Yeah, these are identified risk factors. And again, I don't have the numbers on me immediately. And this is something that's just falling out of my brain. But we look at ulcerative colitis specifically. We do see that, or in Crohn's disease and ulcerative colitis, specifically the breastfeeding and bottle feeding are known risk factors, some more than the others. And I don't want to misquote because the data is slipping my brain right now, but one of them, I believe it's breastfeeding or lack of breastfeeding is a higher risk in colitis than Crohn's, but it's like a 47% increase in chance. Whereas when we look at, again, the opposite one, whichever it is, Crohn's or colitis, C-section birth is another 40 something percent. Birth control, 47% increase in chance. Smoking, something like, again, 60 plus percent. So all these things, these stack. So what we're looking at here is really just the risk ratio. Remember earlier we talked about the NOD2 gene. If you're a double snip of these two gene variables, you have a 17 to 40x increase in chance of getting Crohn's disease. And then the more you stack all these risk factors, bottle feeding and breastfeeding and allergies and medications and antibiotics and all these other factors that basically they determine how strong your ecosystem or that I describe the gut like a rainforest becomes. Because if your gut and your microbiome and your immune system, they work together. They train each other. Your immune system helps keep those microbes at bay from overgrowing, and your microbes train and pressure test your immune system. So between the two, they're constantly back and forth. Well, if you knock one of these things out of the environment, of course the other is going to roam free, right? It's like the wolves in Yellowstone National Park. As soon as the wolves were gone, the caribou overate, they crowded the waters, streams dried up, beavers left, etc. They brought the wolves back, and suddenly everything was flourishing again. It's about
Mhm.
balance in the ecosystem. Breastfeeding, antibiotics, stressors, all these factors throw that balance off, and then we flip and overreact.
Right. So again, to emphasize on the importance of a natural birth, you come through the birth canal, you're inoculated with the normal microbes that mommy gives you. Same thing with breastfeeding. The milk is better than, you know, milk from other animals like cow's milk and whatever. And also around the nipple, around the areola, there's microbes that the baby will suck in, and that develops their GI microbiome or their microbiota. And then, as a youngster, if they're constantly hammered with antibiotics for their ear infections, oftentimes viral ear infections that don't need antibiotics. So antibiotic overuse again helps destroy or put the gut in imbalance. And those often affect people for the rest of their life. So out of the chute, people are, damaged, if you will, by not doing, the best way to come into the world via vaginal versus C-section.
Well,
Because the baby is laid usually on top of mom, and the microbes are whole different microbes.
yeah,
You
it's a whole
mentioned,
seeding. So if I
yeah,
could,
it is.
JP, you mentioned about antibiotics. Even the CDC recognizes up to 30% of antibiotic prescriptions are unnecessary. It's something like 29
Right,
or 30%. It's crazy what we do. And we look
right,
at babies. Look what happens if you help a bird out of its egg. It can die from failure to thrive, right?
right.
Babies being born
And it,
vaginally makes all the difference. All this
yeah,
just even like you mentioned, breastfeeding, it's not just the microbes. I mean, even like sucking on the nipple of a bottle, it's this little thing. Whereas having the full breast in the mouth actually expands the palate and the jaw and the sinuses. Then you're a nasal breather, which increases nitric oxide production, which increases oxygenation. Like, everything's connected. Nature knows what it's doing.
right. As an ER doc, I used to get pressured by mom. Mom would bring her little, 3-year-old in with an ear infection. And I know from experience and also what's in the literature that if you just leave it alone, the ear infection will clear up on its own. So I would push back, and mom's like, well, I want augmentin. It's not just amoxicillin. They want augmentin. They want the big guns. And I'm like, oh my gosh, what is that going to do to that little kid's gut microbes? So I'll say, no, let's hold off, let's watch and wait. This will probably resolve on its own. Well, they didn't like that too much. I mean, I got
Mhm.
yelled at in the ER by a mom who thought she knew better. So she would take the next day, she'd take the kid to a different pediatrician, and they'd put him on azithromycin, or they'd put him on augmentin, and the kid would have diarrhea from that. But the ear would get better. And she'd come in and wag her finger at me and say, well, see, I took him to a different doctor. They put him on augmentin, and my child's better. Well, yeah, the child could have been better leaving it alone. I mean, you can't run it through the lab. But now you
Mhm.
mentioned mold illness or mycotoxin exposure. Can you elaborate a little bit on that with regards to IBD?
Yeah. So right now, we don't actually have hard literature in humans saying, yes, mycotoxins cause bowel disease. But I've seen an interesting pattern. I took 307 different conversation transcripts from initial assessments with clients. So I go through, it takes about 15 to 30 minutes. We do this whole deep dive from birth and build the timeline and story to determine what is the probability, the likelihood of how you got here. And we do that on these first calls. I took 307 of these de identified transcripts. I dropped them into Claude and I asked it, what percentage of these people were either confirmed or strongly suspected to have mold exposure as part of their history or a relative like active part? It was 87%, which that is statistically a bombshell, right? It's this massive thing. So again, we know mold, it disrupts, or these mycotoxins, what mold produces, they disrupt the gut barrier. It leads to broad dysbiosis, that imbalanced bacteria. They can damage DNA and mitochondria. They can lead to genotoxicity and therefore altered gene expression. Well, what is Crohn's and colitis? A weak genetic link that when altered and its expression alters, it causes overreactions, right? Mold toxins damage, we know, the liver and the kidneys, and even compromise bile flow. Like there's so many other things that contribute to IBD from mold. And the nail in the coffin on this one's actually one of the IBD risk genes called CARD9. And this is specifically involved in antifungal immunity. So this is direct genetic environmental interaction pathway that's sitting right at this intersection of mold and bowel disease. We know in the mouse models and animal models, because there's lots of agricultural mold studies done with broiler chicks and cows, that these Th17 immune pathways, for example, Th1 and 2, they're all skewed and these imbalances get thrown off, which are the exact same immune pathways we see implicated in IBD. So the mechanistic connection is really a one-to-one, but because we don't have the paper saying, hey, inhale this mold, did you get IBD? No? Okay. It really needs to be that black and white for medicine to accept it. They don't really like these mechanistic connections. And it's almost as if the minute you bring it up to a gastroenterologist or your average GI, it's like they're allergic to the conversation. It can't be. No, 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 no. They don't even want to investigate. It's very hard to get this recognition for mold, which is clearly at 87% a huge driver.
Right. Well, when you look at GI docs of the past, 20 years ago, you bring up gluten and they'd scoff. And then, well, we check them for celiac and they're not gluten allergic, IgE mediated, but they're gluten sensitive. They don't check them for that. And there's a vast majority more folks that are gluten sensitive, IgG reaction, and it can cause all kinds of problems for people, autoimmune disease and all that. In my practice, I see a lot of folks with mold toxicity or mold sensitivity or mycotoxin illness. It's a tricky thing, and it overlaps into things like Lyme disease and mast cell activation, and you name it. It's got its fingers in about everything. Very hard to nail down unless you do the proper testing. And I've seen people go to an allergist and they get the skin test, the prick test on their skin for mold. Well, that's not what we're talking. We're talking mycotoxins. Those chemicals, they're almost like forever chemicals. They can't be destroyed very easily. It can come from a water damaged house. So you need to have your home inspected and your car and your place of work. If a kid is on the swim team and he's going into a really nasty locker room after his swim practice and is exposed to all kinds of mold, you got to eliminate that before you do any detoxifying treatments. And then we've discovered through some researchers in Europe that EMF, electromagnetic fields, actually cause the mold to release up to 400 times the amount of mycotoxins. So now you've got somebody who's either in a water damaged house or eating food that's got mold on it, corn, grains, things like that. Even the feeding lots that are moldy, you got a pig eating out of that. The mycotoxins actually go into the pig's meat. And even if you fry the bacon, it doesn't destroy those mycotoxins. And then there's
And milk as well.
colonization. Yeah, milk, exactly. So you have to be careful with your food sources, with where you live, where you work, the car you drive. If it's been a water damaged car, you need to get rid of it. But you have to do the proper testing, like urine mycotoxin testing to find that out and find out how affected you are. And then there's colonization. I've had patients well, I sold my moldy house and I, moved to a brand new house and I took all my upholstered furniture, and so they're re-inoculating their new home with mold, and they might
Yeah.
be colonizing it in their sinuses. So there's a lot to it. It's very complicated, and if that's the source for IBD, it needs to be further researched, and look at the clinical evidence. You don't have to do a randomized controlled trial, although that's what a lot of doctors will depend on. But there's faults in that, and we sometimes will not have them fully funded. So you have to look at clinical experience, the experienced clinician.
And
So,
there are issues. Sorry if I can, JP. Just a little
sure,
audio delay. I think I'm cutting you off now. There's issues with mold testing, like you mentioned, like urine mycotoxin. It's great to do, but there are some people who are poor excretors, right?
right?
I think I may have mentioned him here. A gentleman I was working with, 5'9" and 99 pounds when he came in to see us, right? We put him on the Rinvoq. He's that guy. Well, his ERMI test for his home, the top end, which is like occupancy is not advised, is like 15 or 20. His score was 40.8. So his home was swimming. He knew he had mold. He did a renovation, didn't recheck it, swimming in it. But his urine test only showed two mild strains. And we have to
Hmm.
look at even the healthiest body without bowel disease should be peeing all of these toxins out, but he wasn't. So not only is he exposed, he's also a poor excreter of these toxins, which may lead to more colonization. And you're exactly right. Like they're so hard to test for. And this is part of why I think the research isn't there. I think it would be very expensive. And on the back end, frankly, not very profitable.
Right, right, exactly. Yeah, testing is very expensive, and
Yeah.
insurance is not going to often pay for it. So, let's talk a little bit about some therapies, just lightly, because this is a whole other hour conversation on what you do with your patients. Let's take a UC, an ulcerative colitis patient, and I'll start off with saying, you may want to find a Mediterranean style diet, like a green Mediterranean diet. That might be helpful overall. It may reduce inflammation. It's an anti-inflammatory diet. You want to touch on, let's say, the use of curcumin. Turmeric's the spice, but curcumin is the active ingredient. Do you use much of that in your practice?
Yeah, I do. And all of these different things, all these different therapies, I think it's very important to split the difference between plant-based medication and therapeutic intervention, right? And this is something that's very important. I see a lot of people coming in working with their clinicians. They look at the data. Like we know, for example, curcumin with 2 to 3 grams a day. I mean, the studies are showing with mesalamine, but it's got up to a 54% remission rate. Even wormwood, surprisingly enough, 500 milligrams 3 times a day is shown up to 65% remission. Right? Vitamin D can create 53% fewer relapses at 10,000 IUs a day. Boswellia, there's all these different herbs we can use. But I see so many naturopathic doctors, functional practitioners, and they give people all these herbal supplements to manage the symptoms in lieu of medication. It is therefore, by definition, just a plant-based medication. It's a plant-based numbing cream, if you will, for the nail in the foot.
Hmm.
And so
Sure.
my interest here is I want to identify like what is that root cause driver or drivers? Like what are the layers that filled your cup? Number one. Number two, then I can identify what I'm giving you, how long we're giving you it for, and the results we expect it to provide, allowing us to pivot. Otherwise, you get on all these supplements and herbs and things that a lot of clinicians who mean well will give you, omegas and magnesium, and then you're on them
Mhm.
indefinitely with no end in sight, again, to just manage the disease. So
Right.
I think it's a very important distinction to make as well.
Right, exactly. Because the last thing we want to do is get people off of unnecessary medication. The pill burden is heavy. So you go from pharmaceutical polypharmacy to nutraceutical polypharmacy. And sometimes practitioners like myself will they'll overdo it. And you have people on 20 to 40 different dietary supplements and botanicals.
It's like
And
a
so it
pharmacy.
becomes, yeah, because it's a different type of polypharmacy. It's nutraceutical polypharmacy. So we don't want to put our patients through that. But identifying root cause is great. So I published a paper a number of years ago with a Dr. Dinetz in Florida, in Miami, and it was a foreign-born child who came in with Crohn's disease, so bad that his surgeons wanted to do surgery. They wanted to remove most of his internals and put a colostomy bag. Of course, he's a 14-year-old kid. The parents were freaking out. They're like, "No, there's got to be another answer. We don't want to do this kind of surgery that's going to, mutilate our child." And so
Yeah.
Elliot brought the kid in and started running some tests, and we found the root cause. It was Borrelia burgdorferi. So he had a case of chronic Lyme disease that triggered this inflammatory response that caused the problem with his gut, with his intestines. And sure enough, once we treated him, for Borrelia and kind of eradicated most of those microbes, things settle down. We also use low dose naltrexone and some high dose vitamin C. And to top it off, we use thymosin alpha 1 sub Q injections of that peptide.
Mhm.
He goes back to his GI guys. They're kind of rubbing their hands together, thinking, okay, let's schedule him for surgery. They rescope him, and after 3 months of therapy, they can't find any lesions. He's totally cured. And to this
Hmm.
day, I understand that that he remains free of the Crohn's lesions. So we did some dietary things, but it was a combination of finding out the root cause, what triggered off his case of Crohn's, and what therapies we used, low dose naltrexone, some peptides. And it was so compelling. We actually published it as a case study to at least get the word out to other clinicians that, keep this on the radar as a root cause for Crohn's disease. Have you had any similar experiences in your practice with what may have caused or triggered?
Yeah, I've seen Bart's and Babs. I've seen a lot of those Lyme co-infections. I've seen parasitic infections, various types, blastohominus and cryptosporidium and giardia and all kinds of stuff. I've seen fungal overgrowths, broad dysbiosis, you name it. I mean, in my practice now, we've seen nearly 700 different cases from as young as 2 months old to over 80 years old. So we've seen
Mhm.
everything, and I've personally overseen every single case. And so I'd like to say there's not much that surprises me at this stage. We've had people with no stomach, full colectomies, partials, bags, you name it, right?
Mhm.
So there's so many different layers to answer that question. But what's interesting is in nearly every single one of those people, I've seen benefits from three specific diet types. The first one, these are actually researched by Ari Levine out of Israel. That was, you mentioned diet, CDED, UCED, and SCD. Now, the CDED is the Crohn's disease exclusion diet. They actually found 70 to 94%, depending on the sample size, of pediatrics got into remission in 8 weeks, and 60% maintained that after 24 weeks. Whereas adults were slightly less at like 45 to 80% and 40 plus percent after 24 weeks. Now, the UCED, which is ulcerative colitis exclusion diet, that one had a 37.5% remission in pediatrics and up to 40% kept that again at 8 weeks. And then SCD is that specific carbohydrate, which again is 30 to 40% or something maintained for 6 months. In these small pediatric samples, some maintained it at 100%. But what these diets do, they all remove ultra processed foods. They all remove specific carbohydrates, sugars, and other things that actually feed bacterial overgrowth. A lot of these gram negatives or mycobacterium that contribute to the issues. They prevent feeding of fungus, and suddenly that immune system gets turned down. So just like you're talking about Bartonella and Babesia and Borrelia and all these other things, it always fits in that umbrella of toxins, microbes, or deficiencies. That's why we're
Right,
sick.
right, exactly. Josh, before we move to audience questions and bring Autumn in to help us navigate that, I want to ask you if you have any parting shot or any last words on what our paper would be helpful for clinicians and even lay people to take. What's the take home message for that? Just maybe a big summary, and then we can go on to questions.
Yeah, I guess what I'd like to say is that ultimately, as a community, be it a patient or a clinician, whatever it is, if we stick to this autoimmune, genetic, idiopathic model, our only options are medication and surgery. If we can recognize that it truly is none of those things, it's not genetically determined, right? Then that means it can be changed. If environments are things that trigger the disease, you can change your environments. It's not always easy. If it's mold, you have to move or remediate, but it can be done. Not being autoimmune means you're not attacking yourself, but instead your immune system is attacking something that shouldn't be there. Therefore, you can find it, change it, and remove it. Then all of a sudden, you have options outside of medication and surgery in that traditional model, and you actually have control. And now clinicians, They can explain how and why this disease happens and actually investigate some of these primary drivers of the disease. And then parents don't feel guilty about having their kids have this doom and gloom future because, oh, they gave it to them through genetics. And there's hope
Right.
and there's a greater push for research and community involvement and root causes and even potential investment into treatments that work. You know, a weak link doesn't break itself. And with the right approach, you can find out what did. No one's born with these diseases. And even the very early onset cases, like pediatrics, even infants, they have the same exposures. Their link is just weak. And they were handed an even weaker microbiome and weaker immune system due to loss of these over generations that needs help. But instead of fixing it, we manage it. And so I often
Mhm.
describe it like having, again, a nail stuck in your foot. And the only solution we're giving people is a numbing cream. And it wouldn't make any sense if we did that. Frankly, neither does your approach to Crohn's and colitis in the Western world, which is manage it with drugs. And so I'll shut up now, JP, but I think if I had to wrap this up, if you guys couldn't tell, I'm pretty passionate about this disease and I will speak to anyone, anywhere. I will travel wherever that I can in the world. I don't care to speak, to do whatever it takes to get the message out, to do lectures in medical schools and academies, wherever it is. I want to get this out. And so doctors, patients, event organizers, reach out. You give me a call, you email me, I'll come running like the bat signal.
Right. Well, I know your practice in Canada and got some feedback from some patients that we've shared. But like my mentor in Lyme disease, Richard Horowitz, he's coming out with a new chronic illness book in
Mm,
October, 600 pages, and it covers a lot of these things. But he also used the description of, you go to the doctor with a pain in your foot, and you've got 9 nails in your foot. And the doctor looks at it and pulls out one nail and says, okay, problem solved. Well, not really. I mean, there's many, many things to look at. We're complex beings, we're complex organisms, and medicine can be very complex, especially chronic, debilitating stealth syndromes can be very, very complex. So I think, clinicians need to step it up and look beyond their specialty, take a more broader approach, become super generalists so that they can keep things on the radar. Okay. Well, that was great, Josh. Thank you so much for coming on the show. Autumn, before we take off, Autumn probably is going to get some questions from the audience that we can
Yes, I have
hopefully
a
answer.
few questions. Thank you guys so much for this discussion. It's been absolutely fascinating. I wanted to start with Sophie's question. She asked, what type of gut microbiome testing does Josh and you as well, Dr. Saleeby, think is most accurate slash helpful?
Josh,
JP,
why
you
don't you
want to take
start
that one?
off?
All right, I
Well, I
will.
mean, we all have our favorite labs. There are about three vendor labs that I use. Insurance tends to not pay for them. The GI docs, at least in my area, the conventional guys don't usually do them. They do more of the traditional, send a sample to the local lab core to find out what might be growing, especially with the outbreak of cyclospora that we're facing. But we do more comprehensive, CDSAs, comprehensive diagnostic stool analysis. So it's a poop sample, it's a sample of stool, and we run a lot of different batteries of tests on that stool, including things that look at the microbiome and the virome, and then look at enzymes that might be present, inflammatory agents, calprotectin, lactoferrin, things like that. I don't want to get into the weeds on this, but we have about three different vendor labs that we utilize for that. Josh, what do you usually run?
Yeah, there's two different types that I like. Some of them I don't really care for personally. Can I name them by name or is that frowned upon here?
Um, Being a little bit more vague is
Gen-
better.
General
Sure.
vagueness,
General
yeah.
is
Sure,
better.
general vagueness. So there are some big labs that will often utilize, they'll do a deep microbiome test using like a PCR, which gets us really one gene strain, but we can often get different variables of them without their specific genetics. So those are going to be really good. Oftentimes, like JP said, you can get the virome and all these other factors that are information that helps feed that root cause driver. So I like a big comprehensive test that checks for inflammatory markers, neutrophil activity, neurotransmitter function, all these different factors, bile acid flow, etc. The other that I would look for is a shotgun sequencing test. It's kind of one of the new ones, like the cool kid on the block. Whereas these standard tests will check one gene. The shotgun kind of goes through a head count to see really who's in the room, and it sequences all that DNA at once. So you get species level identification, and you call it like a functional analysis of what the bacteria actually do, depending on the report you get. You can actually catch fungus, parasites, viruses, all these different things that regular tests miss. So as a clinician, it's our job to look at which tests are available, what experience do we have with them, and which one has the most applicable information for you right now. But not all tests are created equally, and that's an important thing to note.
Right. And the pricing of those tests is kind of all over the place. You can get a kind of entry level GI map, if you will, for maybe 450, and then there are some that are close to $1,000. And again, most standard insurance companies aren't going to pay for that kind of testing.
Yeah.
I think this is it's a bit of a loaded question. So to simplify, I think you guys might have a few different options for this, but an anonymous attendee just asked, just tips that you guys have for repopulating the gut microbiome. I feel like that could be an entire webinar within itself, but
Well,
any tips for repopulating the gut microbiome?
yeah, I'll tell you what not to do, and then I'll let Josh tell you what his favorites are. So, what
Perfect.
not to do is get an off the shelf probiotic from like any retail store. And I'm not going to mention who they are. Or let's say your local pharmacy, or even sometimes your mom and pop vitamin stores. So they're usually not that great. They're usually not the right mix and can sometimes do more harm than good. So it's best to take advice from a clinician who knows. And there are some very well made pharmaceutical grade companies out there that have spent millions, if not billions of dollars researching certain mixes and blends of things. And I even understand there's an online computer app that helps you identify which probiotic to take for whatever condition or what your GI map shows. Josh, do you have anything to add?
Yeah, I'm a little bit more doomy gloomy on this side of things, and not necessarily in a negative way. I'll explain. I'll try to keep it short. When we look at the gut microbiome, right, there's some really interesting data out there if you know where to look. For example, there was a study that sequenced the gut microbiomes of previously, to this point, uncontacted tribes in the Amazon called the Yanomami tribes. And what they actually found is they had 1,000 to 1,600 unique microbial species inside of their gut, which is considered, that's like the gold medal of the Olympics. It's the best we've ever sequenced. We've never found it. Even the Hadza tribe in Africa, they're out in Tanzania, they had 400 to 750. These are the best microbiomes we can have, right? Hunter gatherers, barefoot, running in the grass, eating off food off the land. Westerners, that same Anglosphere, who's 6% of the globe with 60% of the bowel disease, on average, we have 150 to 300 microbes. Those with Crohn's colitis average 100 to 150, which means they've lost up to 90% of their gut microbiomes that makes their bacteria robust and beneficial, that ecosystem like Yellowstone National Park. And so I do firmly believe we have absolutely extincted, if that's even a word, extinctionary, our gut microbiomes to the point where some of these things we will never get back, which is where truly FMT, I think, will be the future. And I can see where this becomes more commercialized and grown over the next 30 years. It'll be like taking a multivitamin. I really believe that that's possible. And that's probably the best thing we can do for ourselves. But over the counter, spore-based probiotics, high quality probiotics, frequent use of ferments, not too frequent. You'll know if you feel bad, all those things. There are some that do colonize and some that don't colonize and will never colonize. So just do your research, because if you take a probiotic and you feel good, then you stop and you feel bad, it likely didn't colonize. It was just the postbiotics that they produce, the benefits being transient through your system.
Right, exactly. You mentioned FMT, so fecal transplant. Great for people with resistant or hard to cure C. diff. Insurance will pay for that.
Yes.
But you try to order it. I've been turned down from the labs that produce the material. They won't even send it to me for my patients with, a diagnosis of dysbiosis. They have to have resistant C. diff infections to qualify. Yeah, and I said, well, let's not you go through insurance. Let's do private. Let's say this is a cash for care thing. They still wouldn't allow me. So I've had, unfortunately, patients that do it yourself they'll watch a YouTube video and they'll collect stool from their parents or their friends or neighbors. It's not ideal, but sometimes people get desperate and do that. I don't
Can kill you
recommend
though.
doing that. Yeah, exactly. You might
Very dangerous.
inherit something bad that you wish you didn't ever get started. But people get desperate when they get turned down by the medical system.
Well, thank you both so much for this fascinating conversation. I know we have so many other questions that our audience would love to go over, but since we're at the top of the hour, I'm going to switch over to our closing announcements. But thank you so much, Josh, and thank you so much, Dr. Saleeby, for being here tonight. It's a really fascinating discussion.
It's a pleasure.
Been a pleasure. Thanks.
All right. So next week, we wanted to let you all know that Dr. Kat Lindley and Dr. Molly James will be joining us for a discussion on how to get the care you want for $0. They will be discussing the hidden costs in the insurance system, employers' responsibility to oversee healthcare spending, and how direct care, cash pay networks, and self-funded plans can lower costs while giving patients better access to care. That's Wednesday, August 5th at 7 p.m. Eastern. This Friday, Dr. Paul Merrick's newly updated and expanded cancer care guide, approach to the use of repurposed drugs and nutraceuticals in patients with cancer, will be available on our website. This guide provides a practical framework for integrating repurposed medications, nutraceuticals, and metabolic strategies into patients' individualized cancer treatments. Covering more than 30 cancer types and clinical scenarios, this expanded guide provides clinicians and patients with evidence-informed protocols on repurposed drugs, nutraceuticals, and metabolic strategies designed to target the biological drivers of cancer and support personalized treatment decisions. You can download this free guide at imahealth.org. It will be available beginning this Friday. Before we close, we wanted to highlight IMA's new series, Medicine at 250 Years. Each week, we've been sharing new videos and articles featuring IMA Senior Fellows as they reflect on the last 250 years of medicine. Their different backgrounds and medical specialties offer unique perspectives on what medicine has gained, what it has lost, and what should come next. You can explore the full series at imahealth.org. It's currently on our homepage. To close tonight's show, we're sharing one of the videos from this series titled Pathology, Innovation, and the Body's Capacity to Heal, featuring Dr. Ryan Cole, IMA's Head of Medical and Scientific Affairs. This is a shortened version of this video, so if you'd like to see the full clip, you can find it on our website. Thank you all so much for joining us, and let's take a look.
I'm Dr. Ryan Cole, Head of Medical and Scientific Affairs for the Independent Medical Alliance. As we celebrate 250 years of history, it's interesting to look back on each profession and subspecialty and how things have evolved here in America. Pathology, okay, I'm one of those nerdy pathologists, but it's the story beneath the surface. Pathology is basically looking for truth in medicine. And, to compare it to what the founding fathers did, pathology is basically a rebellion against unexamined authority. So for so long, we believed in the theories of the ancient Greeks or Galen, the humors, the bile, the phlegm, etc. And as we made scientific advances, von Leeuwenhoek discovering the lens and the invention of the microscope, we found that there was a completely different world. I like to joke that the pathologist is the most important doctor that you never meet, that you always hope is right. And that's true. We have this special calling in medicine to be behind the scenes as a support, a doctor to the doctor. And as we make a diagnosis, we're consulting with your physician, your clinician, helping them understand what the findings mean. So that innovation in medicine was really put forward and advanced here with thinking in the last couple of centuries. And then here we developed incredible diagnostic tools. We became, for better or worse, the first country to really have a big public health system, which used to be a good thing. And we can get back to that being a good thing. We think of all the advances that we think we've made in science and diagnostics and medicine. But think of all the generations that made it here without the advances that we do have. We're here today because people were resilient and they lived in harmony with nature and found things from nature that helped heal. And so absolutely, medicine is miraculous in many ways, but so is the medicine of nature herself. And the best of medicine uses both of those responsibly and in harmony. So here we are in a new era. Patients want answers. They don't want just a label. My profession, lab tests, pathology, we can certainly clarify what's happening in the human body, but that should lead to care of an individual. So a diagnosis should be the beginning of a deeper conversation with your healthcare provider. It should not be the end. So we're in this wonderful transition period as we've gone through another hiccup in history the last couple of years and are still fighting that battle in certain ways. We need to certainly have scientific rigor, but we need to have biological humility. We need to look back and say, they figured it out long before we had all these tools. And it's exciting to say, hey, here's a new innovation. We can celebrate the things we can do, but do they do the things we need them to do in the context of real health? So we need to remember the body is an amazing machine that can repair itself when given the right conditions. And all the diagnostic tools in the world can be present. But if we aren't cognizant of our own health, being our own best doctor, being part of that caring community, then where are we? I mean, that rural family doctor with the black bag is kind of the picture in everybody's mind, visiting the mother in the home and attending to her. But we have this opportunity to really find balance in life and say all the science in the world is great, but if we disconnect it from basic cycles of life, then I think we're heading the wrong direction. So I'm blessed to have so many of these aspects of modern science in my life. I'm also blessed to keep bees on the farm and live with the soil and live an organic regenerative life in my little circle of day-to-day activities on top of all the other responsibilities. And I think if you think of the founding fathers and if you think of the amazing rebellious citizens of this nation, they were in tune with nature. So this is an example for us. In this next era of medicine, 250 years behind us, hopefully a good 250 years to go. But this next era of medicine must be advanced enough to see disease at the cellular and the molecular level, certainly. But medicine needs to remain humble enough to remember that healing still depends on the entire whole human being. May the next 250 years be a blessing for not just us, but obviously our children and our grandchildren's grandchildren. Thank you.